afternoon, everyone, and welcome to the 33rd installment of the University of the Philippines and the Philippine Health Insurance Corporation's Stop COVID Deaths webinar series. I'm Dr. Raymond Francis Sarmiento from the National Telehealth Center, and today is a day for special topics again. And as always, I'm very happy to share hosting duties with my mentor and partner in crime, the special envoy of the President for Global Health Initiatives, Dr. Susie Pineda Mercado. Dr. Susie?
Thank you very much, Raymond, and good day to everyone who's joining us live. And for those of you who are on the playback, welcome to the webinar series. We're taking a break from the virtual grand rounds, and we've got a very special topic. You know, one person dies from renal disease every hour in the Philippines, and with COVID, think access to services, particularly dialysis, has been such a big problem. So we're dedicating this web to talking about dialysis and COVID. So stay with us. We've got great guests, and there is a lot that you're going to learn today. Raymond.
Thank you, Dr. Susie. And for those who are joining us for the very first time, those who are watching us on the live stream, the YouTube channel of TVUP, I'd like to remind everyone that in terms of our flow of discussion, we will have our resource persons give their presentations. That will be followed by a panel discussion, and then we will be entertaining questions from the audience during the Q&A session. But before we proceed, let me take this opportunity to thank the very hardworking team behind the Stop COVID Deaths webinar series from the University of the Philippines System, and also from our partners at the Philippine Health Insurance Corporation, the UP Manila National Telehealth Center, UP Information and Technology and Development Center, or ITDC, without whose support this webinar will not be possible. And also, more especially, a special mention po to TVUP, the Internet Television Network of the University of the Philippines. We also have very extremely hardworking people po over at the College of Medicine and also the Philippine General Hospital. So maraming salamat po sa lahat sa patuloy din pong panonood at pagsubaybay and making this learning series possible. Dr. Susie?
Okay, so we've got very special guests who are going to talk about dialysis and COVID. But before we do that, I just want to greet some people who have put in the chat box where they are. So we'd like to have a shout out to our friends at Villa de Lid Negros Occidental. That's Marichelle Morales. And from Santa Teresita General Hospital, Joseph Tortona, who always watches. And Joan Uba from Tamolatan Medical Hospital. So wherever you are, babatiin namin kayo as we go through the webinar. We're just so happy that you are spending this Friday with us, and we hope that what we discuss will be very helpful for your practice and for stopping COVID deaths. Raymond, I think we have an opinion poll.
Okay, but before we present the opinion poll, for those who continue to ask, to continue to hound us, and to continue to really request about the electronic certificates, TVUP, may I ask you to flash our slide or video on it? So for those who are asking for a copy of their certificates, or those who are eligible are only those who have spent at least 50% of the webinar duration in Zoom po, and they will be receiving, along with their e-certificate, a copy of the presentations given by our resource persons. So please stay tuned po. And as always, like I always want to mention, those who are still asking for certificates, dun pa po sa Season 1, all of the certificates, at the very least for Season 1, have been distributed na po and have been really disseminated to those who were eligible. So if you did not receive that, probably please send us a line, and we'll try to figure out what happened. But for those who are asking, ito po ang itsura ng certificate of attendance.
Raymond, wala ba akong ganyan?
Yes, meron po tayong lahat niyan, Dr. Susie, even our resource persons po. So those are who are asking po kasi ano pong itsura ng certificate, did I receive it, or do I need to answer an evaluation poll to receive it? Yun po, just if you are spending or have spent 50% of your duration of the webinar here to join us, you will be eligible to receive it. And those who are joining us in YouTube po, sana po ay you have that time to also to transfer to our Zoom webinar. We have a maximum capacity of 3,000 attendees, so hopefully we could take advantage of that po. And then for the one that was requested by Dr. Susie Mercado, may we flash on to the screen our opinion poll po.
We're going to introduce pala the guest speaker muna before we do the
Okay,
opinion.
no, let's leave the poll po and then go ahead with the introduction, Dr. Susie.
Nagulo kasi ako dahil sa, never mind, I won't make an excuse. Anyway, we are very privileged today to have the Executive Director of the National Kidney and Transplant Institute, none other than Dr. Rosemary Rosete-Liquete. Dr. Rose, welcome to the webinar. Rose?
Yeah.
Okay, hi. Good afternoon, and thank you so much for joining us. We know you're very busy, and that NKTI has been very busy also. Kamusta po kayo, ma'am?
Yeah, we're okay with COVID and now leptospirosis.
With leptospirosis, so this is because of the recent floods?
Recent flood, yes. The recent flood. After the Ulysses, we were deluged also with patients with leptospirosis and some COVID combination.
Okay, so we have a lot to talk about. So, Ma'am Rose, go ahead and give your introductory remarks.
Thank you very much, everyone. Magandang hapon po sa inyong lahat at sa mga viewers natin. I think all over the Philippines, I hope. So, to everyone and the organization, of course, and to UP naming mahal. Ngayong umaga po, pag-uusapan ang tungkol sa dialysis sa panahon ng COVID. What are the challenges and opportunities? COVID has taken toll on the lives of the Filipino people. The COVID crisis exposed the vulnerability of our healthcare system, especially in the care of our dialysis patients. In this exchange of ideas, strategies, and innovations will be discussed as to challenges we meet along the way. Challenges which have turned the disaster into opportunities, into something that will pave the runway towards efficient healthcare delivery system. To engage in virtual sessions as this is already an opportunity for everyone to harness at its best what technology could offer. Yes, we shall talk about our focus on dialysis care during the COVID times, but on the macro level, I hope we should also think on a bigger scale how to improve the whole system. So welcome everyone, and surely we shall learn from each other's experience and wisdom.
Thank you very much. Thank you very much. That was Dr. Rose Liquete, the Executive Director of the National Kidney Transplant Institute. We are going to hear more from Ma'am Rose later, who will be a reactor in our panel. So, Ma'am, dyan lang kayo. We are going to listen to your presentation later. Okay, Raymond, go ahead with your opinion poll. Raymond, you're on mute. You're on mute.
Thank you, Dr. Susie. Sorry about that. I'm not sure what is happening, but we've relaunched the opinion poll pa, and hopefully our more than 220 attendees here will key in their answers po. And towards the end of the webinar, we hope to be able to get an idea on how these will be correctly answered. For the very first question, we have: should dialysis centers ever turn down their patients who develop COVID? So very controversial po, no? But so yes and no lang po ang pagpipilian. So we hope a lot of our attendees are able to participate in this poll. Number two question, when should frontliners in a COVID dialysis center be tested for COVID? What we have po are option one, when the frontliner is symptomatic. Na option two, regularly. Option three, when exposed to someone who is COVID positive outside of the dialysis center. And option D is all of the above po. So lahat po ng mga choices na nabanggit po dito. I will be reading po the list of those who have registered and who are joining us in this webinar. Let me just pull it up po. Okay, so where is it? Okay, so we have attendees as mentioned, and for our guest speakers from the National Kidney and Transplant Institute, those who are joining us and watching us all the way from Florida Blanca in Pampanga, from Jose Panganiban Primary Hospital Service Cooperative Camarines Norte in the Bicol region, from Silliman University Medical Center in Dumaguete City, from the DSWD Regional Rehabilitation Center for Youth in Polanco, Zamboanga del Norte, and the Philippine Association of Medical Technologies. We also have our international attendees watching us all the way from Prince Sultan Cardiac Center in Riyadh, Saudi Arabia, and our regular from the Niagara Falls in Ontario, Canada. So maraming salamat po again sa patuloy po na pagsubaybay, lalo na po kung kayo po ay nanonood sa YouTube. Kasama rin po kayo dito. And then finally, for our third and final opinion question, should the dialysis center be closed kung meron pong pasyente or healthcare worker na maging positibo po sa COVID? Again, medyo happy po ang ating mga kasagutan from our attendees, but hopefully we have a better sense on how we should be answering and will be answering these questions. Please continue to key in your answers as I give the floor over to Dr. Susie Mercado.
Thank you very much, Raymond. I can see in the chat box we have people also watching from Calibo, Aklan, Iloilo, gosh, okay, Camarines Sur and Zamboanga del Sur. So again, thank you for joining us. You know, we're able to do this webinar because of you and for you. And so let's start. Raymond, you know, the National Kidney Transplant Institute prepared short video clips on some of their patients. Yeah, so you want to cue that now? Maybe we can.
Okay, TVUP, may we have those videos po from dialysis patients seen at the National Kidney and Transplant Institute.
Nahirapan ako maghanap ng dialysis center. Hindi ako tanggapin.
Nahirapan din talaga kami maghanap sa ngayon ng dialysis center na pwede kong paglipatan. Sa gawa nga po ng una-una tinitingnan po namin yung PhilHealth kung nag-accredited sila.
Okay, natatakot ako kasi unang-una hindi ko alam kung kanino ko pwedeng maaring makuha yun dahil siyempre iba-iba yung tao nakakasalamuha ko. Tapos, yung mga narinig kong mga epekto na nakakamatay siya. Lalo na kung ikaw ay mayroong pre-existent na sakit. Mas delikado yun. Siguro mas, ang narinig ko mas okay kung, let's say, nagka-COVID ka, pero wala kang pre-existent, parang makakasurvive ka pa eh. Pero pag may pre-existent ka, parang magdudong lalabas yung mga iba't ibang komplikasyon. Takot? Hindi naman ako natakot. Malakas ang pananalig ko sa Panginoon na kahit may pre-existent na sakit ako, carry ko yan, kaya ko yan, lalabas ako ng buhay sa NKTI.
Ang naging epekto sa pamilya ko nung nagpasok ako ay siyempre distansya. Nalungkot sila dahil kailangan may sundin kaming paghiwa-hiwalay para safe yan lahat. Bumukod ako. Nakakalungkot po talaga.
Oo, natakot ako dahil sa COVID-19 na yan. Gumagamit. Oo,
Dati hindi ako tatanggapin hanggang hindi ako negative. So, natutuwa ako kasi at least sa NKTI. At least, dito na ako magda-dialysis. Hindi na ako mahihirapan. Like, yung mga kasama kong iba nahihirapan maganap. Yung positive ako. Pag ako nagpaswab uli ako, negative na ako, babalik na ako doon sa center ko. Oo, hihirapan ako. Basta positive ako, pero
Hinihintay po namin yung mag-negative ako dito before ako lumipat doon. Kung saan kami pwedeng tanggapin ang dialysis center mas malapit sa amin.
Okay, thank you from the National Kidney Institute, and I think seeing the patients and hearing what they've been through is quite touching. 35,000 Filipinos are on some form of dialysis at any point in time, and over the past few months, so many dialysis centers closed down, and patients who needed dialysis had nowhere to go. And in the middle of the storm, of course, is the National Kidney Transplant Institute, where everyone started to go. So we are fortunate to have the Deputy Executive Director of NKTI, who is Deputy Executive Director for Training, Education, and Research, Dr. Romina Danguilan, PNG Danguilan. PNG, welcome to the webinar.
Hi, Susie. I'm going to share my slides.
Yeah, wait, before you share your slides,
Okay.
tell us what the situation is like now. I mean, like today, I heard you kanina, you were rushing, no? And Ma'am Rose said, maraming may leptospirosis. What's the situation today at the NKTI?
Yeah, so as Ma'am Rose mentioned, we have a deluge still of COVID, though much less compared to the height of the pandemic, which was March and April. So we have about 50 patients with COVID still admitted at NKTI. We had to open our gym now, our basketball court. It's full of patients with leptospirosis. So total, we have about almost 80 patients with leptospirosis. And we have a couple of patients, maybe about 5, with combined COVID and leptospirosis. So again, a very interesting disease on how, a bacteria and that virus interplay in a patient's symptoms. So we're very busy all the time, but we're getting used to it. Like lepto, we have that every year, so we know how to manage it. COVID, we're getting better and better. So we're here to accept any challenge that comes our way.
Thank you very much, Benji. I cannot help notice the painting behind you with butterflies. You want to tell us something about that?
Yeah, because every year for the last maybe 5-7 years, we always have contests during a World Kidney Day. That's in March, and we invite students, and sometimes it's professionals to submit to us paintings about kidney disease, about hope, giving hope to patients with kidney disease. And then these are the winners. So the one behind me was made by a student. And all over NKTI, if you go through all our corridors, you'll see beautiful paintings from students, mostly really amateurs, and the rendition of either kidney transplantation, peritoneal, or hemodialysis, and just giving hope to everybody that even if they have kidney disease, there's so much to look forward to in life.
Nice. Okay, nice story, beautiful painting, and what a wonderful message, a message of hope, no? Which I think we all need right now. Okay, Bench, go ahead and share your slides.
So I'd really like to thank Susie and her group at the UP for giving us this opportunity to share with you our experience. Actually, it's really our journey on how we dealt with dialysis during the time of COVID. Do you see my slides?
Yes, that's very clear. Go ahead.
Okay, so I'd like to start with the situationer in March 2020 what was happening here at the Institute, then proceed with the ER COVID complex and dialysis and how we did that during the time peak period of COVID, then transitioning back to the wards, and then the new normal dialysis. I showed here a picture of our dialysis units. On top, that's our hemodialysis main, where we dialyze our inpatients, and the picture below is our chronic hemodialysis unit. So what are the NKTI services for dialysis that we offer at any time? We have hemodialysis. So we have a 31-station chronic hemodialysis unit. We have a 15-station chronic HD unit as an extension, because 31 stations running 24/7 hours was not enough. Then we also have our 16-station acute hemodialysis unit for inpatients and emergency room patients who are coming in who have to be dialyzed immediately. Then we also have peritoneal dialysis, which is our option. Actually, PD first is what NKTI offers. We have a 19-bed PD ward and a CAPD clinic that looks after more than 1,000 patients on peritoneal dialysis. So what are the numbers? We have about 350 chronic hemodialysis patients. All hemodialysis units, as I mentioned, run 24/7. We have more than 1,000 chronic PD patients on CAPD. And we have also, in addition, CRRT, which is 24 hours or longer slow dialysis, hemodiafiltration, a special kind of hemodialysis. We also offer hemoperfusion, which has been used in COVID as well, which removes cytokines in patients who are septic. And we have our automated PD, the cycler, for our patients who are initiating on PD. Let's look at the situation, or what was happening to us in March. It was enhanced community quarantine. Remember, in Luzon, it was declared on March 15. And at that time, NKTI decided upon Dr. Liquete's assessment of the entire hospital together with our EXECOM, we decided not to admit COVID positive patients to our wards, since NKTI patients are all vulnerable patients. We have transplant patients, nephrology patients on immunosuppression. So our dialysis patients are all vulnerable. The wards and dialysis units as well required retrofitting for a highly infectious organism. We did not have the infrastructure required to prevent contamination or co-infection in our wards, even in our dialysis centers. So we had to beef that up for the moment. So it was the decision not to put the patients inside our wards. So NKTI built from the ground up a maximum of 17 tents with a maximum of sometimes 100 patients all over the grounds of NKTI. So let's look at the ER COVID complex, which is what we made, and dialysis. So this is just a snapshot of the number of daily new patients with COVID-19 and its 7-day average. Here, when it was ECQ, you can see the number of patients was still low. Then as we proceeded into MECQ, you saw that that's about May time. There was still stabilization of the number of patients coming in with COVID. But when it became GCQ and a relaxation, patients were already going out of their homes, you see that there was a tremendous rise in the number of new cases coming to us every day. So because of all the patients that were coming, we had to build our NKTI ER COVID complex. If you know, this is East Avenue. You enter here through our gate 2. You already will be welcomed by our triage, manned by our adult nephrology and internal medicine residents and fellows. Then here you see a driveway with the arrow, and you see here an island. But if you look beyond, you'll see we have a lot of tents here for patients, and other tents here for various kinds of patients. That was in March 14. Again, here's a snapshot of our triage tent. All of these tents, some of them we had to buy. Others were really donated by the Philippine National Red Cross, by DSWD, and by some very, very good private donors. Here we had to make a surgery tent for vascular access for dialysis and some urologic procedures. And here's some working station tents of our staff. Now, we had to do a reality check. Remember, I said we did not want to admit any of our patients. NKTI was not a designated COVID hospital. We had Lung Center, PGH, and we had later Tala Hospital that were designated COVID hospitals. So we expected COVID hospitals to take our referrals, but it rarely happened. In fact, we were very disappointed. The hospitals I mentioned, they either had no vacancy, they were also full themselves, or they were not ready to take care of our hemodialysis patients. They either had no hemodialysis or they lacked machines, and they certainly did not have any peritoneal dialysis fluids to support our patients. So what was our solution? Our solution then was we had to build our own hemodialysis tents in the ER COVID complex in order to take on and continue to provide service for dialysis patients coming to NKTI. This is an example of the first NKTI ER HD tent. You can see it's a military tent. You see Dr. Liquete, Dr. Mike Haro, who was really responsible for building all this infrastructure, and our staff. This is HD Tent 1. It was air conditioned. It had exhaust fans to provide some air exchanges. There were 4 hemodialysis machines, and we had a portable reverse osmosis for water treatment. Then at the same time, we already built again a second hemodialysis tent. So here you see them with 4 machines each. And you see here a patient actually being wheeled into that ER hemodialysis tent. You see now the staff, they're all wearing hazmats, and you see trailing with an oxygen tank. This is so that was very early, second week of March. By the end of March, it was not enough already for our 8 machines working 24 out of 7 dialysis shifts. We had to expand again. So we had an HD Tent 3. It had 8 HD machines, and in fact, we already needed a crude tank to store source water so that we wouldn't run out of water during the middle of the day. Remember now that all of these tents that we're putting up for hemodialysis require so much water, and the water line comes very far. It comes from maybe about how many feet? Maybe about 20 feet or further away from that area. So we had very long lines of water from our water source providing water for our dialysis treatments. Here you see inside that tent, you see our staff nurses with their hazmats and performing dialysis on our patients with COVID. So what were the challenges with this reality check? We found that patients from other hemodialysis centers were coming to our ER uremic from being unable to dialyze for several weeks because they were COVID positive and were not accepted to their own hemodialysis centers for various reasons. Their hemodialysis units closed, COVID positive healthcare workers, so they had no staff, and these standalone centers had to close. Some of the standalone centers are located in buildings, and of course, they are subject to the will of the owner of the building. And when there was a COVID healthcare worker, they were ordered to stop. So what else? Patients newly diagnosed with ESRD continued to come to the ER for dialysis initiation. Now, you can imagine how difficult this was because at that time, it was ECQ, even MECQ. Patients couldn't come because they were being halted. Even if they go by ambulance or they say, no, they're too sick, a lot of patients were afraid actually to go to hospitals. They didn't know what would happen, and they were afraid of being exposed to COVID. But still, we had the patients coming into us who required dialysis initiation. Another problem, we could not discharge our COVID positive patients who recovered already, but were still swab positive. So they were already asymptomatic, they were already well, but a swab was still positive because their barangays would not accept them. So, we would tell these issues to the DOH, please help us, please talk to the LGUs to accept these patients. Another is the quarantine facilities. Yes, there were quarantine facilities, but they did not want to accept our dialysis patients as well. So the quarantine facilities really wanted well patients without any comorbidities because they didn't have any staff to take care of people who had some kind of illness. So what else? We were also sending our swabs for COVID to RITF, to National Red Cross, since we were not yet doing our own RT-PCR swabs. Thus, there was a huge delay in proper cohorting of patients for dialysis. So we had COVID suspects, COVID positives, COVID negatives, but the COVID suspects were the most number of patients because we had no swab result yet. It would take weeks, several weeks really. Sometimes the swab results don't even come back because these hospitals also probably getting too many patients as well. So these opened doors for opportunities. We admitted all of the HD patients to our ER tents and dialyzed them in our hemodialysis tents. Newly initiated hemodialysis patients and discharged hemodialysis patients were accommodated in our ER HD tents as outpatient dialysis until they became COVID negative. We opened a COVID positive OPD shift in our hemodialysis tents. So the tents were dialyzing ER COVID, so they were inpatients, and OPD COVID. So we had a total then of about 16 stations of hemodialysis facility in our tents. Now remember, we had a chronic hemodialysis station of 31 plus 15, so that's 46 stations. These were all going on as usual. We had a 16-station inpatient dialysis in the hospital that was going on simultaneously, and yet we were able to open a 16-station hemodialysis facility in our ER COVID complex. So no one was left behind, and we expanded to offer hemodialysis to both our ER and OPD COVID patients. What else? We applied for accreditation to perform our COVID RT-PCR and got it on May 25. And you know, we have to really thank Dr. Rosete-Liquete for this because she was really hands-on, talking to the head of our laboratory, liaising with other hospitals to teach us how to do it systematically and how to do it very efficiently. We also applied for accreditation to perform the COVID gene expert and got it on June 24. So we know that the COVID RT-PCR takes quite some time. So we wanted to get the COVID gene expert so it could be done more quickly. So by June 2020, we were able to get the results of the COVID tests within 6 to 24 hours and could properly cohort all patients prior to hemodialysis. Now, our IPCC was telling us when you dialyze COVID suspects together, so let's say we have a 4-cubicle station, that COVID suspect, even if they're wearing masks and shields, are exposed for 2 to 4 hours to other patients. So the risk for the other patients getting COVID is very high. So that's when we really decided before any patient is dialyzed, we need to know exactly what they are. Are they COVID positive or negative so that we can cohort them properly and safely. So how did we manage all the dialysis patients? These were our opportunities. We had ER HD cohorting, COVID positive, suspects, but that disappeared later when we had our testing, and COVID negative. ER HD OPD shift for COVID positive. So they were coming to us even if they were already going home, coming for their OPD as an OPD for hemodialysis. We also had an OPD shift for patients on quarantine for 2 weeks before returning to their own HD centers. So we have patients who have COVID, maybe they're already negative, so they go home. But our rule is before you go back to our chronic hemodialysis center, you have to be on quarantine for 2 weeks before you can be accepted back. So during that time, where do they dialyze? So they dialyze during our OPD shift. Then we limited the dialysis to twice a week only instead of 3 times during this time, just so that we could accommodate all our patients. With all of these, 1 to 4, it was not enough to dialyze all the COVID patients. This is an example of the number of patients that we were dialyzing then. So here we have, you see in blue, the inpatient or those who were dialyzing in the ER. You can see sometimes 70 a day. Then you see here the daily average of our outpatient in yellow. So when we started already our outpatient HD, look here, we were doing about 20 to 30 patients a day. And our hemodialysis inpatients, sometimes we would max it up to 60 to 70 in a day. So what did we do again? Another opportunity. We offered HD patients to shift to peritoneal dialysis, so they would not have a problem looking for an HD center since dialysis is done at home. And we wanted to initiate new patients on peritoneal dialysis, part of our PD first, but we needed a sterile operating room in the ER complex. So at this time, our operating room in the hospital was closed. Only emergency renal patients could have their operations in our operating room inside the hospital. We had no kidney transplantation at that time. So where is this operating room where we would do our PD catheter insertion? Because it requires a sterile OR. So what was our solution? With Dr. Liquete, she decided, okay, we build a sterile OR in the ER COVID complex. And I want to show you where that is. So here's a parking area at the back of our emergency room or diagnostics building. So here you see the shell of that. And here you see it's almost finished with our staff, our engineering, our OR staff, and we have them led by Dr. Mike Caro. And here we have now our OR that's finished. And we built this in 5 days, and we're very proud of that. So we were able to build a sterile operating room here in the ER COVID complex, built in 5 days. It was a requirement by our surgeons for PD catheter insertion. It was now in place, and we were now ready for PD initiation and other procedures. This is to show you our NKTI ER PD tent. So you can see that the patients are divided by physical separators. And here we call that the gondola tent. It was, again, a donation by one of our private donors, and it had 16 beds. So with the opportunities on managing our dialysis patients, we have number 5, we offered to shift the HD patients to PD, and newly diagnosed ESRD patients were put on PD. We were able to shift 2 patients from HD to PD, and for newly diagnosed ESRD patients, we were able to initiate 41 patients on peritoneal dialysis. So what are some of our other NKTI SOPs for COVID dialysis patients? All patients should have an RT-PCR COVID test done before hemodialysis. So either RT-PCR or Gene Expert when it became available. We strictly cohorted our patients. So start with clean, then go to dirty being the COVID positives. We would dialyze sometimes only for 3 hours instead of 4 so that we could dialyze everybody on that day. And once on outpatients, we would dialyze them only twice a week instead of 3 times a week. We had no dialyzer reuse at that time, so always a new dialyzer. And this time, it's because we want to protect the healthcare worker. So we were able to find some information that the dialyzer or dialysis fluid may be contaminated with COVID. So we felt that it was a risk for our hemodialysis technicians if they would reuse these, if they would, undergo the treatment to clean the dialyzer. So our policy was no reuse. And then after every HD session, wipe down all the equipment. Then we do a UV light exposure for about 15 minutes in our hemodialysis areas. So then we go now transitioning back to the wards. How did we do that? Now, retrofitting of the second floor wards was already completed by that time. It was May, and it was also start of the rainy season. We had 1 typhoon during the tents, and some of the areas were, became muddy with a lot of water. So we decided at that time in May that we needed to turn down all of these tents. So tents were slowly taken down and patients were admitted to the COVID wards. The second floor wards were retrofitted. And so that time we had 95 COVID beds, and our intermediate care unit of 4 beds was also relegated to our COVID positive. So that was middle of May. Then HD machines in the tents were moved into a 12-station hemodialysis unit in the ER extension temporarily. So here you see the ER extension. we were able to put 12 hemodialysis stations here, and we were dialyzing through cohorting the ER inpatients and even our OPD patients at that time. So that was also in May. Now, what did we do in preparation for our in-hospital hemodialysis units? This is current now. We have our 16-station hemodialysis main. We do HD cohorting. So shifts 1 to 2 are for COVID negative or those with pneumonia. And shifts 3 to 4 are those for COVID positive. Now, as we speak, shifts 1 to 3 are now for COVID negatives and pneumonia. And we only have 1 shift a day. So that's 16 people who are COVID positive. We also added a 6-station hemodialysis area on the 3rd floor for our COVID negatives. So patients who are admitted in our 3rd floor, they dialyze here. Then we also placed, again, Rosete-Liquete, wanting to protect our transplant patients. We placed a 2-station hemodialysis area in the 3rd floor, Annex 1, for our kidney transplant patients who are COVID negative, of course. So they're coming in for transplantation, but they need maybe 1 dialysis before that. So this is where they are dialyzed, so they don't mix with anybody. And then lastly, our 8-cubicle ICU and our 4-cubicle intermediate care unit are all plugged in for HD, so we can dialyze patients there at any time. I wanted to show you the patients that we were dialyzing. Mostly, they were old or chronic hemodialysis patients here in blue, and compared to the ones who were newly initiated in red. So every day, we would dialyze about 28 chronic HD patients and 8 newly initiated dialysis patients. Now, where were the patients coming from who were coming to our emergency room? You can see here that the daily average non-NKTI HD patients were about 25. So they were coming from outside NKTI. They were not our chronic HD patients who dialyze here in NKTI. And in fact, the daily average of NKTI hemodialysis patients was only 2. So you can see that majority, sometimes here, 60 patients a day, here, 40 patients a day, and now it's gone down already. But most of the patients were patients who were chronic dialysis patients dialyzing outside NKTI. And here, just to show to you the treatments that we were giving. So in light yellow, those who are not on dialysis, about 13 a day. The kidney transplant patients in orange, maybe only about 3 a day, very few. Our peritoneal dialysis patients, about 37 a day. And our hemodialysis, really the bulk of all our patients, about 71 patients a day. So this was how is the distribution of the dialysis services we were offering to our patients. So this is a summary of the NKTI COVID dialysis patients. Since March 14, 2020 until December 2, 2020, NKTI has admitted 813 COVID patients, 76% on chronic dialysis or newly initiated on dialysis. So you can see that our demographic in NKTI, almost 80% of the patients are on dialysis. Mean age is about 50 years. Our male to female ratio, a little predominantly male. The mortality of COVID confirmed patients on dialysis is 28%. That's high, but low if you look at the dialysis population. But if you look at the regular people, a general population, it's under 5%. So if you have a severe disease, in our case, dialysis patients, it's 28%. And the leading cause of death in 72% was severe pneumonia. What's new normal dialysis now at NKTI? And I'm almost ending. This is the new normal for our chronic hemodialysis center, which is here. In order to enter that corridor, you have to go through a triage to check temperature and to answer the COVID checklist of questions. Then here is inside our chronic HD. I wanted to show to you that patients wear masks at all times and face shields. Before, they would only be required to wear that when they would have cannulation or if they had some symptoms, like if they were coughing. But now it's required that they wear it throughout the dialysis period. And here again, you see our healthcare workers wearing their mask, shield, and gown at all times. Susie, I want to show you again the pictures that you see here in our hemodialysis unit. Again, these are from our contest where we have students mostly who are giving us very beautiful paintings. Now, what about our inpatient dialysis? So we have converted this to a hot zone. So the 16 cubicle acute HD unit, you see that it's a hot zone. So the staff are all wearing hazmats. And here inside the cubicle, again, you see staff wearing hazmats. And for our hot zones, our patients are also required to wear mask and shield during the full treatment. And I wanted to show this to you just to show that we kind of parallel the nationwide weekly cases. And this is taken from www.doh.gov. We see a peak during August because of relaxation of quarantine. And you see that also happened in NKTI. But as we have shown, there's a reduction already here by October. And we also have experienced that reduction in NKTI as well. So opportunities, how do we solve all this problem? Can our inpatient HD ever get to be normalized? And the answer is yes. And again, through the efforts of Dr. Rosete-Liquete, talking to IATF, talking to DOH, and really pressing on, we have to move forward. They are now giving us or helping us to put up our here soon to rise our NKTI COVID Dialysis Center. So it's going to be a 20-station hemodialysis center, which will dialyze only our COVID positive patients. So at least we can remove the OPD patients who are still dialyzing in our COVID hot zone in the hospital and transfer them here outside in this new center. And hopefully this will be available for our patients in December 2020. So I'd really like to thank our NKTI HD staff because really they were very resilient, they were very reliable, they were there all throughout. Some of them were sick, some of them got COVID, but we never closed operations. As I told you, our chronic hemodialysis never stopped, even if we kept adding and adding hemodialysis stations all over the hospital. And here we have our chief hemodialysis nurse, Beth, who really was very key in implementing smooth sailing of our hemodialysis services. I cannot forget our NKTI adult nephrology fellows who you see here, who again remained so resilient despite getting COVID, despite the duties they had to do. We like to thank them for ensuring that our dialysis services remained always there. And I'd like to thank you for your attention. And again, soon to rise our NKTI COVID Dialysis Center. Thank you so much for listening.
Thank you very much. That was Dr. Romina Danguilan, PNG Danguilan, Deputy Executive Director of NKTI. What an amazing story, and we salute all the workers of NKTI. I think this webinar really gives us an opportunity to see what's happening behind the scenes, no? And really laudable everything that you've done, and you're getting a lot of congratulations here on the chat box. And we want to hear, we will hear some more, and we will take questions from the audience in a moment. So thank you very much, Dr. Danguilan. Let me turn over to Raymond to introduce our next speaker. Raymond.
Thank you, Dr. Susie, and thank you for that excellent discussion, Dr. Danguilan. I think nangangati na po ang ating mga audience to ask questions. But before that, let me introduce our next speaker po. And she is, well, you already know her. She has been a regular po in this Stop COVID Deaths webinar series. She is a professor at the University of the Philippines College of Medicine and is the current president of the Philippine Society of Nephrology. She is none other than Dr. Elizabeth Montemayor. Dr. Beth, welcome po to the webinar, ma'am. Welcome again pala, ma'am, to the webinar.
Hi. Hello. Good afternoon, and thank you very much for inviting me again to attend this very highly informative webinar. And I'm really very happy that you've been doing this since the beginning of pandemic, and you still are continue doing this. Thank you very much.
Well, thank you. We're the ones who should be thanking you, Dr. Beth, because of you're really very willing to share your expertise to everyone, not just in the Philippines, but internationally. I won't keep you from your talk, ma'am. Please go ahead and share your slides.
Okay, so I'll just a brief reaction on what happened during the day among the dialysis patient during this COVID period. Okay. So just some statistics on COVID-19 and dialysis. And this is just an example of the incidence of COVID among the hemodialysis patient in one particular unit. This is local data, about 20 out of 90, so that's 22% of the hemodialysis patients had COVID, and there was 25% mortality. That's really a high mortality. And among the healthcare workers, we really have a much higher incidence of COVID positive COVID positive healthcare workers, although we had zero mortality. Now, for patients who develop acute kidney injury requiring dialysis, mortality is even higher, approximately 35 to 50% of the patients who would develop acute kidney injury requiring dialysis would have a high mortality. In the Philippines, as of December 2, 2020 census, we had about, we're going to the 500,000 mark, we're nearly going there, and the death is 2%. No? So this mortality rate is similar worldwide, and you can just see that patients hemodialysis patients would really have very high mortality. In the literature in Italy, for example, they had a 15% incidence rate of COVID positive among the dialysis patients, with again a very high mortality, 29%. And in New York, they reported that the deaths among dialysis patients who became afflicted with COVID was 28%. We know that the hemodialysis patients comprise a distinct population in this COVID-19 outbreak. They are a vulnerable group. They have to undergo a procedure which is life-saving. And we said that mortality is very high. So, but what really sets them apart is that they are a relatively large group. Worldwide, there are about 2 to 3 million patients on dialysis. In the Philippines, we have here the registry from the Philippine Disease Renal Registry. In 2015, we had about 50 patients on dialysis. Of course, the number is larger now, and this is reflected by the amount of expenditure that PhilHealth this is reflected in the expenditure of PhilHealth. In 2015, the PhilHealth expenditure for hemodialysis and peritoneal dialysis was 6.5 billion. In 2019, the expenditure for hemodialysis alone was approximately 10.5 billion. So you can see that we do have a large number of patients on dialysis. Now, the hemodialysis patients are mobile. They have to undergo the dialysis procedures. It's life-saving. They travel from home to dialysis facilities and other healthcare centers. And this gave them the opportunity to develop the disease itself, or they serve as potential vectors for infection. The hemodialysis patients also receive lengthy treatments in close proximity to other patients and the dialysis staffs. And in close proximity to other patients and the hemodialysis staff. And because of their multiple comorbid conditions, they have impaired immune system. So many patients have actually closed during the pandemic. We had, as of my record, we had about 8 hemodialysis units which closed during the pandemic. And one of these units is a very large unit catering to more than 200 patients. So this really created a crisis. And this prompted the Philippine Society of Nephrology to create the Task Force COVID. So in July 2020, we created the Task Force COVID, and this came about because of the displacement of patients who tested positive in a center which has no capability to dialyze COVID cases, and because also of the closure of the dialysis centers brought about by limited sources. They now lack the funds to operate, and the staff issues. And we said that I've presented the data that a lot of nurses and technicians developed COVID-19, became positive. So they have to close because there was manpower issue. Many nurses also and many other healthcare workers would resign from their job, not because they had COVID-19, but because they have fathers and they have parents who would tell them and who are so protective of them and who would tell them to resign from their position because they are really afraid that the mother, the wife, or the child will get afflicted by the COVID. So what are the answers to our problems? We had targeted the local government units, and we established partnership and agreement geared towards helping the dialysis patients in the areas for their constituents. So we had open communications between the nephrologists in the area so that the local government units and the health officers will work hand in hand with managing these patients who turn out to be suspects, probable, or confirmed. We also had dialogues with the Department of Health, with PhilHealth, with IATF on the creation of dedicated dialysis units. Hopefully, we were trying to place them beside the quarantine areas, but of course, it was a very complex situation. In the end, the PSMN membership rose to the occasion and created the dialysis unit, which are dedicated for the asymptomatic outpatient dialysis center. The partnership with local government has been highlighted here. And here we're showing the Rizal group of nephrologists who had partnered with the provincial government of Rizal for the mass testing of their COVID-19, for the mass testing of their hemodialysis patients. And of the total of 284 patients whom they tested, 12 asymptomatic patients tested positive. So this led to the prompt action. This led to the prompt action of isolating these patients and hence mitigating the spread of the disease in the unit. The Philippine Society of Nephrology also came up with prevention and control infection guideline in the hemodialysis facility. This guideline was made together with the Philippine Society of Microbiology and Infectious Diseases and the Philippine Hospital Infection Control Society. And some of these, and these are the topics in the issues discussed in the guideline. Infection prevention and control guidance for hemodialysis facilities, placement of COVID-19 suspect or confirmed patients in the hemodialysis facilities after hospital discharge, the assessment, and this DEF are really big issues because one of the problems that had been presented by Dr. Danguilan, they had COVID asymptomatic, they have patients who are already asymptomatic but still COVID positive, and they are still kept in the hospital because the barangays and the hemodialysis units would not accept them. So this answered that particular questions, D, E, and F. And one of the questions asked in your poll was what happens when there is a dialysis, when there is a patient who developed dialysis, COVID, who became COVID positive in the unit, and we have one of these provisions will answer that question. So for the healthcare workers, when can they return to work? We have also tried to answer that particular question. The pandemic has also highlighted the advantage of peritoneal dialysis as a form of renal replacement therapy, as discussed by Benji. And we are now emphasizing the role of peritoneal dialysis as an option for renal replacement therapy. Most of the patients who are on peritoneal dialysis, among patients who are on peritoneal dialysis, very, very few really develop COVID-19 because PD is a home therapy option. So they just stay home. They don't become exposed. They don't get exposed to the community. It requires less equipment and infrastructure when compared with extracorporeal dialysis, and it offers lower work intensity with the nurse being able to manage at least 4 PD cyclers. PD catheter insertion can be made at bedside with local anesthesia, although the National Kidney Institute built a sterile OR where they can insert the peritoneal dialysis catheter. It is also an easy method for nurses to learn than to learn how to handle the complicated CRRT machine or the hemodialysis equipment and techniques. And there's really minimum contact with the patient, and this reduces the risk not only of the contagion, but also the need for personal protective equipment use. And so such efficient resource management method helps address the shortage of the medical equipment and reduce exposure of the healthcare staff, which are critical issues amid the pandemic. There's really a disproportionately high rate of COVID-19 among patients on dialysis. And this is brought about by their limited ability to physically distance themselves. When they do get the disease, mortality is very high. And there is also a high rate of COVID-19 among hemodialysis healthcare workers. When they do get the disease, services to the patients also become compromised, and this is just coming from the point of view of the patient. It is therefore important that we intervene to reduce the threat of COVID-19 in this very vulnerable population by focusing on the modifiable factors. And this include universal masking of patients and staff, enhanced screening, and include testing of COVID-19 patients who are asymptomatic during the times when the local prevalence is very high. Thank you.
Okay, thank you very much. It was Dr. Beth Montemayor, the president of the Philippine Nephrology Society. She's also professor at the University of the Philippines and was one of our first speakers who talked about ACE2 receptors and the role of ACE2 receptors in inflammation in COVID. So thank you very much for that. And I'm very glad to hear about peritoneal dialysis. In our time, I don't know about you, Raymond, but in our time, that was what we were doing. Wala pa masyadong hemodialysis noon, you know. So I think our audience has many questions, but we still have one more reactor. So let us bring back and welcome back Dr. Rosete-Liquete, the Executive Director of the National Kidney and Transplant Institute. Rose, go ahead and make your presentation.
Thank you very much, Susie. Indeed, you had a very good discussion today. You just had a treat of the beautiful slides and, of course, the brilliant minds of our previous speakers. Indeed, these challenges have brought out the best, if not the very best, of our Philippine team in the eye of the COVID. Hold on.
Yeah.
Okay na?
Yes, ma'am, we can see.
Yes, you can see it. Okay. At the NKTI, of course, we were deluged with a lot of dialysis patients who are COVID in renal failure. We dedicated almost 100 beds from the hospital, and aside from those in the tent, which also had around 100 patients in the tent. I believe we did very well with our COVID field. It's with the following services. We had hemodialysis, as mentioned, the peritoneal dialysis. We also had radiologic equipment in our tents. And aside from that, so you can see here from our tent, the field tent, we also had the satellite operating room. We converted rooms to improvise negative pressure so that later on we could bring up some of the patients in the tent. And we built our own hot zone within the hospital. Should NKTI be the only center to go to when we have for our renal COVID patients? What happens if we face another pandemic? Are we equipped? When an infectious disease is fulminant, it is inevitable that the patient can go into renal failure. Currently, we have leptospirosis patients and they go into renal failure. And worse is that we have leptospirosis patients who also have simultaneously or who also have COVID. There are several concerns I would like to highlight. Where must we bring our COVID patients? In one of our meetings with the Department of Health, as early as like maybe it was January, we suggested that we put up a centralized facility, a field hospital, wherein we have the suspects or the COVID positives equipped with all the tests and possibly isolation areas and dialysis stations. We even suggested a sprawling place like in UP Diliman and even the Quezon Institute area. But then the answer was, Dr. Rose, we are talking only of short term. As you can see, it has become a long-term concern. All hospitals were asked to assign COVID wards. Then health workers became positive because we got, all of us got the COVID patients. Then one hospital command was born. Selected hospitals were augmented with dialysis machines, but the infrastructures had yet to be established or to be built. And where were the nurses? Focusing on dialysis needs, NKTI has a list of nurses whom we have trained in the past years. And then we furnished the Department of Health of this list. But unfortunately, these nurses were already employed or have gone abroad or refused to take care of COVID patients. Nationally, maybe we could maintain a master list of nurses or even doctors who, like in the Army, are called reservists. They are recalled for hospital duty when the need arises. Just like now, it's a COVID war after all. Where are the diagnostic facilities? If you remember, Dr. Penji said that for up to 1 to 2 months, we had no results coming in. Our swab results came in later or not at all until we had our own swabbing facilities. Now we have more than 100 COVID testing facilities in the Philippines. But sad to say, these have come much too late. and unable to cope up with the influx of OFW and LSI. Not all of them were screened before they went back to the provinces. Meanwhile, they stayed in congested areas in Manila and contracted COVID. Regions should be equipped with COVID testing labs or other tests on microbials with potential to create another surge of infectious disease or pandemic in the pandemic level. RITM is a Center for Infectious Disease, but it needs to be strengthened. There should be more RITMs in the region in strategic areas. Of course, we are an archipelago with so many islands. They should be in strategic areas or places, especially to serve the GIDAs, the geographically isolated disadvantaged areas. How was the service delivery network? Metro Manila was divided into quadrants, but I don't think it really helped us at all. Our quadrant some of the quadrant didn't accept our patients. Hospitals were mandated to allot 30% of their hospital beds, and we even gave more. Then came one hospital command, but again, manpower and rooms were not enough and were not even ready. Regarding dialysis, most of the freestanding dialysis actually closed down due to COVID. Although some freestanding dialysis accepted COVID positives and built some tents outside their area. I don't know if SPMC is listening now, Southern Philippines Medical Center in Davao. SPMC accepted all COVIDs, of course, because it's a general hospital. And what they did was that they transferred their non-COVID HD patients to freestanding dialysis centers who did not want to accept COVID. So it seems simple. So, okay, we will get the COVIDs, but you get our non-COVID patients. That was an innovative move by the Southern Philippines Medical Center. How can we cohort the community? Sorry. And where are these facilities? OFWs and LSIs were jam-packed in isolated facilities. Although the government agents were engaged on this, I will not deal much on this. It is their concern as much as ours, although they owe it to the community. The role of the media. We had to have our own media mileage. We declared that we shall cater only to renal patients, especially those on dialysis. Somehow this parried away referrals who were not renal cases. But then the problem came when we had no more beds and dialysis slots for them. So we have the media, through the media, we should let the people know what's the real score. It was only when NKTI went into there that people realized we actually had more patients than PGH, than Tala and the Lung Center. And we had more dialysis patients. With the media exposure, we also got the sympathy of the public. And of course, donations kept coming in, not only in terms of PPE, but also in terms of food to our frontliners. We should reach out to our government and NGOs. Centralized, coordinated governmental or coordinated action is critical during any resurgence. There is a need to act collectively and quickly in support of hospitals and healthcare providers as they continue to struggle. So we got more PPEs, we were able to get transports, kasi sa umpisa, we were like kulang sa pansin. We got accommodations for our health worker, like a dormitory facility. And soon we will have that hemodialysis facility for the COVID. We hope it will be started by next week by the DPWH. Will all our renal and dialysis concerns be addressed by the universal health care? As you know, UHC Act 11223 was signed February 2019, almost just before the surge of the COVID. So as shown here, it has to provide the highest possible quality healthcare to the Filipino people. And on these pillars, a robust health financing, we have to have our experts in our health facility, and of course, the health human resources. The resource stratified framework for renal care and transplant centers will reveal a roadmap from basic primary or intermediate towards the advanced comprehensive centers to the national specialty centers, which is supposed to be NKTI. You can see here that in the municipality level, there should be standalone specialist outpatient facility. And it is included there that they can have dialysis centers in this area. So not all patients will be coming to the National Specialty Center anymore like the NKTI. So all of this, I believe, will be universal health care will be able to bridge the gap. More dialysis, renal care centers, especially the Nigidas, enhanced service delivery network, established testing laboratories. We improve communication as we have been doing now. We encourage training of homegrown professionals so that we will not lack nurses anymore, especially those, and the doctors also, especially those in the rural areas where we need doctors and nurses. Telehealth is very important. Raymond would agree to that. We'd agree to that. So we build the regional centers for infection, promote research, support scholarship programs so that we will have more doctors and nurses. And of course, we need reasonable compensation for our health workers. And although off tangent, control population explosion. We know that it's the COVID is mainly in the NCR because we are much highly populated. How can you control a disease when you have a huge population like what we have? And the national ID system should be very helpful for all, not only for our patients, but for everybody, so that we can reach out to them, we can cohort them, and of course the DSWD can give their ayuda efficiently. And of course, this has not been enforced yet, national ID system. So I'd like to end my talk to this. Thank you very much.
Thank you very much, Dr. Rosete-Liquete, the Executive Director of the National Kidney Transplant Institute. So we're going to have a bit of a discussion, and we'd like to call everyone in and have everyone on the panel. So Dr. Liquete, Dr. Montemayor, Dr. Danguilan, Raymond. Okay, so we're all here now. And well, we thought that maybe we'd start out by asking you to answer the questions to the opinion on Raymond, right? Because it's like we wanted the
That would be
audience.
helpful po.
We do have over 300 participants, again, coming in from many different parts of the country. On my count here, Raymond, it's 335. I don't know how many we have on YouTube. But, and we'd like to greet all those who are at the National Kidney Transplant Institute watching your bosses here. So, Raymond, let's start with asking them to answer the three questions.
Okay, let me pull that out. Okay, the first question po is, should dialysis centers ever turn down their patients who develop COVID? So there are only two answers, yes or no. And majority said, 90% po said no, but there's still a little over, so almost 90% said no, a little over 10% po said yes. So ayun po. And then the next question, I'll just go over the questions po before we answer.
Yeah,
The
go
next
ahead.
question, When should frontliners in a COVID dialysis center be tested for COVID? When the frontliner is symptomatic, testing should be regular, or when the frontliner is exposed to someone who is COVID positive outside of the dialysis center, or all of the above? All of the above was the answer of most. 74% of respondents selected all of the above. And finally, it's another yes or no question. Should the dialysis center be closed if a patient or healthcare worker becomes COVID positive? So yun po, those are all of our 3 questions.
Okay, we're gonna ask our panelists to address the questions. So anyone can start. Benji, you start.
Yeah, well, for me, question 1, my answer is no. Um, you have to be able to do something or strategize so that you don't turn away your patients. Now, we know it was quite an unexpected pandemic that came to us, but right away, you should be able to strategize on how you can retain your patients. And the very first thing to do was to cohort. So you should have already cohorted the time of the dialysis sessions to have a COVID session. And then, of course, you have to have your adequate PPE also. Now, I think that there were some who said yes because they are now looking at the logistics part, okay? The staffing part. So that becomes a very critical issue. But in general, I think that all dialysis centers now, we've been exposed to COVID. So let's strategize and see what measures to take so that we do not dislocate the patients, because it's going to be very detrimental to them. Some of them have gone to our emergency room severely uremic because of not being able to dialyze in the last 2 weeks. So that's really something that we should really avoid. It should be part of the responsibility of the dialysis center to take care of their own patients.
That is definitely that is no is compromise. No is probably the right answer, but we should also consider the capacity of the dialysis centers to accept these COVID positive patients, because most of them really do not have the capacity to accept or to dialyze the COVID positive patients, no. And that was the main problem in the early days of the COVID pandemic, when a lot of patients are turned away. But nowadays, many dialysis units, especially the freestanding ones, have already offered an outpatient COVID positive, an outpatient for the stable COVID positive patients. So now I don't think that's a problem anymore. The COVID positive patients can be referred, if they are dialyzing in the freestanding units, they can be referred to the freestanding units also catering to COVID positive patients. Of course, the hospitals will not have any problems there, because the hospitals have already their own logistics in dialyzing their own patients, whether COVID positive or COVID negative.
Yeah, thank you. Thank you for that. Ma'am Rose.
Yes, that's a very good question actually, because I know some dialysis centers who didn't actually close down. They just cohort the patients and then maybe put them on the last shift, okay? One center even put up a COVID tent. So only COVID patients there and only nurses dedicated for the COVID. Because you cannot send away these patients to other hospitals. Maybe when they are serious enough that they warrant admission to the hospital, yes. But they can, of course, Beth, the capacity, of course, of the freestanding dialysis should be taken into consideration. But, you cannot dislocate these patients when they have been dialyzing in this center for a long time.
Yeah.
You're being compassionate also that they can still there. But there's that stigma also that if you're positive, oh, you should not be with us. And some patients, the other regular patients would be worried also to be infected. So strategy na lang yon, i-cohort mo rin sila. And one thing is that you can do testing also of the patients and also the health worker so that they would know that they are also being taken care of by health workers who are not positive. So abilidad na lamang yon. But one thing that the SPMC did was that since the positive patients were sent to SPMC and they lack machines or dialysis slots, so okay, exchange tayo. We send you our non-COVID. Well, that was a good deal, which I really appreciated.
Yeah, you have raised many issues about this situation, and I guess so. My question is, NKTI adapted, right? You adapted. You got deluged by patients. You didn't have facilities. You didn't have material resources, and you were losing human resources. So I think what I want to hear is how how have you been able to keep your staff? And you mentioned that the staff were getting sick and their family members didn't want them to go to work also. So that was the issue in the freestanding dialysis centers. But I'm
Yeah.
sure also
We have to congratulate Susie, our dialysis staff, because people would work overtime, and then we have some staff or ward staff who were former dialysis nurses, or they attended already a dialysis workshop. So we took them back into the hemodialysis unit from being a staff nurse back to the hemodialysis unit. And I was really very impressed because even if they had some people not coming anymore, they were going on sick leave and everything, we never stopped. They never told me as the dialysis center head, they never told me, Doctora, we can only do 3 shifts today because we don't have staff. Never. That never happened. So really, it's the loyalty, the compassion, as Dr. Rose said, that our staff showed their willingness really to work even beyond expectations.
So how do you, Benji, how do you sustain that? How do you support that? Because I think that's where the lesson is, di ba? Dahil sa ibang dialysis center, sa kanila sila, wala kasing tao di ba? Walang staff. So how do you keep your staff motivated?
Well, government gave a lot of leeway here. They had, Dr. Rose is again the master planner of this. They had free accommodation, free transportation, free meals. We did everything that we could possibly do to support them so that they will be able to come to work. Because some during lockdown said no transpo. So okay, we established a transportation. We're very happy that government was able to have shuttle buses that would pass our route. Nung una pa nga, hindi kasamang NKTI. So Dr. Rose said, call up and ask them to have a station where by NKTI so that our employees could go down. So we really tried to support all their other needs so they would not have to worry about where they would sleep, where they will eat, etc. All of that was provided by the hospital. And I think if you show the employees that you're doing everything that you can to support them, then they're very happy. It will command their loyalty, and they also see that the people, their leaders, are working as hard as they are. I mean, Rosete-Liquete, she would even go to our COVID ward. Ako nga, I'm so scared to go to the COVID ward, but Dr. Rose should go there. We'd even tell her, Doc Rose, please wear N95. I think the employees saw, oh my God, these are our leaders. They're here right beside us. So they really work as hard, no? And really beyond expectation.
So
Yeah,
these,
that's the difficulty being faced by the freestanding units because they're so dependent on PhilHealth, on what the PhilHealth gives them, and they cannot stretch it out to free accommodations, free meals, free transportations for their healthcare workers.
yeah, that's a very good point. That, no?
Beth, I wrote letters also to the government to support also the freestanding dialysis. And I know that some of them were also given some support in terms of PPE.
Yeah, PPEs, but which actually we've been soliciting PPEs for the freestanding units.
Thank
Yes,
you.
the problem with our employees, no, they live far apart from Bulacan, ganyan. But with transport, we got military truck. Natutuwa naman sila sa military truck namin. And ano ba, yung mga UV Express, donated by Congressman. That's what I said about you have to knock on the government, other government institutions, benevolent NGOs, and also to the media. Sila naman ang magdadala ng istorya eh. So at NKTI, like this. So hindi na kami kulang sa pansin, and they augmented also our efforts.
I think, Susie, we can share with, like Beth was talking about our freestanding dialysis centers. Let's learn from the experience of how NKTI was able to do all the things that we were able to do. Maybe now, as early as now, they should network with government, with LGU, so that every time there's some kind of catastrophe that comes, you already have a linkage, a memorandum of agreement. There are a lot of LGUs that are so resourceful now, like I think Pasig, Mandaluyong. We hear a lot of good stories there. Of course, we link up with our Quezon City government until now, so that when things like this happen, it's already SOP that they know you need transport, so that they will send you all these buses, all of these shuttle buses to assist you. Maybe now, Beth, we can ask our freestanding to liaise with our military, because they're also very helpful. They have a driver, soldier, sundalo, the driver, a military truck to pick up employees. So I think there are a lot of things that we can learn, so that we can capacitate our freestanding, because we know that they have a lot of limits.
Well, I think they have utilized that. They availed of the free transport offered by the government. But of course, you know that there are so many freestanding units. You're just talking, it's so easy to say NKTI kasi iisa lang siya eh, di ba? We're talking about hundreds of freestanding dialysis unit. It's going to be very difficult to cater to all these.
Okay. Thank you po for those responses po. But just in line with the discussion relation po to PhilHealth, let me just read one of the comments that we have, especially from Dr. Narciso Tapia, who typed in his comment, and maybe our esteemed panelists po can provide a response. The comment reads, during this time of COVID, the difficulty is despite statements from PhilHealth that the extension of dialysis benefits will be continued or extended until 144 sessions by dialysis centers, according to Bayanihan Act 2. Some centers are still not following that directive because they are still looking for the implementing rules and regulations from PhilHealth, which until now is not available, resulting in the cash out of patients, some of which cannot afford it. So, any response po with regards to this comment? Maybe from Executive Director Liquete po muna. Nakamute po kayo, ma'am. Sorry po.
At the outset, we wrote PhilHealth several times, and finally they extended the dialysis sessions. Now it's 144 until December 31. Now, as to cash out, I think it depends on, Benji, can you enlighten us also with some cash out at
Yes.
NKTI?
The problem kasi with PhilHealth is that they have experienced, they are very delayed in paying dialysis centers, even NKTI, no? So we don't know what the issues are. I'm sure there are with PhilHealth. They also experience closure of their offices that are in charge of claims because of COVID. So we also wrote them about that, as Rose mentioned. So because of the poor payment of PhilHealth to our dialysis centers, and as Beth mentioned, the major payer of dialysis centers is PhilHealth, then you find a dialysis center without the logistics to support further payments, further services to their patients. Lugi na nga sila, hindi sila binabayaran, they're totally dependent on PhilHealth, and yet then now PhilHealth extended their benefit, but the dialysis centers are still unpaid. So it's really a very tricky problem, and I really also have sympathy for the dialysis centers. You don't have the, yung PC na mahaba of hospitals na you can just keep on spending. Dialysis centers have to pay suppliers, the salaries of their staff. So I think that was a major reason why perhaps there was some delay in freestanding to support this enhanced benefit of dialysis to 144 sessions. So I think that's the reality, and that's really what we have to contend with. Remember, Susie, even Senator Gordon, he went to media and said, we're not doing any more testing because PhilHealth owes us $1 billion for testing. So similar to that is what happened, Raymond. How can a dialysis center continue giving a benefit of dialysis when they don't have enough cash? Because you have to pay your suppliers, otherwise you will not be able to continue operating. So we need a very good network or link up with PhilHealth, because they should know that for the dialysis centers, the major payer is really PhilHealth. If they don't pay you, and if they don't pay the dialysis centers on time, then we cannot really expect much. These dialysis centers will close. And in fact, a lot of them have closed because of non-payment by PhilHealth. So I'm sure PhilHealth knows this problem. They appreciate all of this. And I know that the society also, under Dr. Beth, have had multiple sessions talking to PhilHealth. So we're all trying to do our best, but really that's the reality. There is a delay in payment for the dialysis sessions.
Yeah, thank you very much for that, Benji. I think the hit on the system has been severe, even on PhilHealth. And we're not gonna go into all of those issues. But I wanted to ask you. I wanted to ask the three of you, because Benji, you mentioned in your presentation that we could have been better prepared, and we should prepare. So I think so what I want to ask all three of you is, what are the three things we need to do knowing what we know now, right? Because when I look at this webinar series, we've identified a couple of conditions that are really time sensitive. So pregnancy, like lalabas yung bata, so kailangan tulungan mo, di ba? Same way, mga acute surgery or cancers, chemotherapy that's needed, no? Not that other things can wait, but there are some that are really time sensitive. And I think end-stage renal disease or chronic renal disease is one of those, no? That if you don't intervene, as you said, within 2 weeks, then your patients are in the ER and they're uremic, okay? And then you cannot reverse it anymore. So knowing what we know, what would be the three most important things we need to do so that if not if, this is going to last. Now, this is not going away. Next week, we're going to talk about the vaccines, but the vaccines are not really going to stop the pandemic yet. So what do we need? What are the three most important things we need to do so that we can address the problems of renal patients in the country? And you've mentioned many things, no? The, what about outside of Metro Manila? What do we do in human resources? PhilHealth's not paying, etc. What do we need to do? So anyone can start. Three. What are the three most important things?
Well, maybe I'll start that we need to instill confidence in the patient that the hospital is a safe place to go, because a lot of our patients are really afraid. I don't want to go to the hospital. I don't want to make admit. They just see our emergency room and it's actually full of lepto patients, but they don't want to go there. They don't want to wait. So we need to show that to the people, no, that it's safe in our hospital. You can come here. Yes, there's COVID, but COVID patients stay in another place. So I think we have to do that also. We have to ensure that the hospital is safe for patients who don't have COVID, that we do all our best to ensure that the COVID positive patients, it's an infectious disease, they're separated from our other patients. We are used to this, Susie, because we have TB. We even have MDR TB. So we're used to having some isolation area. So maybe we need to expand isolation areas and really retrofit them so that they're safe for infectious and a contagious disease like this. So let's make our hospital safe. Let's show our patients that we really can handle an infectious disease like this in terms of infrastructure, even in terms of our emergency room, that it's separate for the COVID suspect from the non-COVID. And if we can show this to our patients, then they'll come here for their prenatal checkup. They'll come back to our hospital to do their cancer screening tests. They will not delay surgeries that are what they call imminent or really necessary. So I think that will be a very big first step, and it'll really pave the way for health people going back to doing their health needs, their patient checkups.
Thank you, Dr. Danguilan.
Yeah, I'll mention the second pointer, Susie, and that is we should not relax our guard and continue with all our preventive and control measures. For example, in my unit, the last COVID positive patient was recorded in July. So we never had a new COVID positive patient yet. So there's this tendency to forget what has happened before. And since you're not seeing new patients anymore, you tend to relax the rules. No? So you will see some staff allowing the patients to eat in the unit. So that means removing their mask. So we really shouldn't relax our guard. We should still continue all those preventive measures of wearing the mask, and hygiene, physical distancing, all those things.
Thank you, Beth. Ma'am Rose.
Yes, if the government cannot provide a centralized facility for this COVID or any infectious disease, I believe the NKTI has had this drill already of having this field hospital. So we must always be ready on this. It's like a field hospital that is to cohort our patients to keep the hospital safe, of course, knowing we have immunocompromised patients. And then network with other hospitals. Itong ganito, sa inyo na yan, hindi na sa amin yan. Of course, we will support you. Networking is very important. And the third is human resource. How can we resolve this human resource problem, especially in the lack of nurses and doctors going back to the provinces? We cannot tell the LGU sa inyo ito, wala naman silang specialty din na ganito pala. So sa atin pa rin pupunta rito sa Imperial Manila, no? Kidney Institute. So I think that's very important. Support our human resource thing. So I think that's it.
Thank you very much, Dr. Rose. Raymond, let's pick up some questions from our audience.
So some of the questions po have been answered, but I probably just pick out a few from our regulars po. And this one po comes from Ses Lim. How often does the hemodialysis patient get his or her RT-PCR test as a measure and as part of his or her weekly dialysis po?
Well, in NKTI, we only do regular testing if you are in the hot zones, as we call them. So let's say our hemodialysis HD main is only for COVID. So the staff there, they also rotate. So usually before they end the rotation, they will be tested. So that after that, they are off for about 3 days so that we know when they come back where they will be assigned. So we only do testing for our dialysis staff if they are in the COVID dialysis area. We have a chronic dialysis facility. There are no COVIDs there. As I showed you, we triage carefully. We have specific guidelines on outside patients who are coming to NKTI. They have to have a negative swab, a negative x-ray. So we're very strict in who we allow to enter our chronic HD. So since our chronic HD, everybody's wearing the proper PPE, then we do not do surveillance for our HD staff and our medical people in our chronic dialysis facility. So it's only those who work in the COVID hemodialysis area.
Okay. Thank you, Dr. Danguilan po. My next question is for the President of the Philippine Society of Nephrology. Ma'am Beth, this comes from Raymond Magini. There are no nephrologists in GIDA areas or geographically isolated disadvantaged areas. Physician on duty starting to become expensive because they are paid by the hour. Is there something that the PSN is doing about this po?
We're just really trying to address the lack of nephrologists in those areas. So right now we're encouraging establishing training institutions in the area in the areas near those areas. No? So for example, Mindanao. Well, we've been encouraging big training institutions there, to establish a fellowship training program. So far now we have about 8 new training nephrology training programs.
Okay, thank you. Raymond, in the interest of time, we're going to ask our guests to give their parting messages. We've still got a lot of people on the webinar and more on YouTube right now. So we'll start with Dr. Rosete-Liquete. What's your parting message for our audience?
Thank you very much, everyone, for listening. And I hope we have reached all of you all over the Philippines or maybe abroad. So something to ponder about, of course, is that our Philippine team is not that well equipped in terms of maybe resources, financial and the human resources. I hope everyone would consider, say, I mentioned about a reservist thing, like the nurses or the doctors. No, if anybody can initiate on that, and then maybe we will have these doctors and the nurses to be recalled to service, something like that. Thank you very much, Susie and Raymond.
Thank you very much, Dr. Beth Montemayor.
Yeah, thank you very much for this opportunity to bring out the plight of the hemodialysis, not just the hemodialysis, but the patients on dialysis. And we said that they are a very vulnerable group and that we have to protect them from getting afflicted with COVID-19 because the mortality is very high. And we should really emphasize on the modifiable factors, the things that we can do, protecting them, like making sure that everybody wears face masks, that we don't relax our rules on the prevention and control of COVID-19 in the dialysis unit.
Thank you very much, Dr. Montemayor. Dr. Danguilan.
Yes. The Filipino has shown resilience in the face of this pandemic. And we, the healthcare workers, we find ways, we strategize to be able to accomplish our goals with all the limitations that we have. We should always continue to do this. We should never allow anything, even as big as this pandemic, the way it hit us and that we were unprepared. We should never make that a reason for us not to be successful. And I hope that our presentations today has shown everybody that there's a way. And with the resources that you have, you can be very successful. And lastly, dialysis is a treatment for end-stage renal disease. It's a treatment that cannot wait. So we really need to find ways that we can continue providing the service to our patients, again, despite all odds. And it's part of our responsibility to be able to do this. So we need to think about it very carefully and look for ways in which we can ensure that if this pandemic or a worse one or another catastrophe will come our way, that we're ready. And I think we all have the capacity to do this. And I'd like to thank again the UP webinar group, Susie Raymond and the team. I see Dr. Charlotte there. She's my classmate. She's also online. I saw Dr. Menchit Padilla kanina. Thank you so much for giving us these webinars. They've always been very, very helpful. And thank you so much for all of this.
Okay, thank you very much. It's Dr. Penji Danguilan. So I think we started out our webinar listening to the patients and quite moving videos of how they were afraid, sad, didn't know where to go, were not being accepted for dialysis. And then we heard Dr. Danguilan talk about, how the surge or the increase in cases occurred when the quarantine requirements were relaxed, and there was a deluge of patients and what they had to do at NKTI. And when I think about it, right? So they actually did their own testing. They cohorted patients. They reduced the number of hours for dialysis so that they could dialyze more. They reduced the number of times patients would be dialyzed in a week, and did many other interventions. One of the issues brought up was that even if patients were already cleared in terms of COVID, but were still testing positive, they would not be accepted by their barangays or dialysis centers. Dr. Beth Montemayor talked about the issue of health workers and how partnerships with LGUs has been very important. She also mentioned how peritoneal dialysis is one of the solutions for the current situation. And I think she highlighted that these patients under dialysis have a very high risk for infection. When they do get the infection, there are high mortality rates. And this puts them in a really very precarious situation. Dr. Rose talked to us about COVID as a war. And I think she touched on many of the health systems issues, from health facilities to financing to the healthcare workers themselves. And we've seen throughout the presentation how her leadership has brought NKTI to where it is now. It is able to respond to the needs of those who are being rejected. But in their recap on what needs to be done, because again, this is going to continue, or there may be situations that are worse. They reminded us that, I think Penji said this very nicely, we know how to handle infectious disease. We know how to do that. And we have to remind our patients and the public that you won't get it in the hospital because the hospitals are now ready. And I hope the hospitals are. The hospitals are ready. We know how to handle infectious disease. This is not rocket science. We know how to do it. And I think we have been given enough time to prepare and to do that. Um, Dr. Beth talked about not relaxing the basic public health interventions, wearing of masks, washing of hands, social distancing. And I think Dr. Rose was making a call for reservists, for those who are probably not in practice or hesitating to be on some kind of a reserve force to be able to respond to the needs of our patients. So I think this has been a great webinar. We are grateful to Dr. Liquete, to Dr. Danguilan, and to Dr. Beth Montemayor in full force talking about how we can address the issues of renal patients in the country in the time of the pandemic. So maraming salamat po sa inyo. Next week, all right, next week, don't miss it. Again, another very interesting topic. We are going to talk about vaccine updates. So what's the plan? Are we buying vaccines? Where are we getting them? Who's going to get the vaccines? How will this be distributed? What's the roadmap? What do we actually know about the current vaccines that have given all their press releases, but we actually have not seen the papers yet. We've just seen what they claim. What are we going to expect in the next few months? So we are going to have an update on vaccines. So join us next Friday. Don't miss that episode where we're going to talk about updates on COVID-19 vaccines. Over to you, Raymond.
Thank you so much to our esteemed panelists po, and thank you, Dr. Susie. It's very rare that we have three of the topmost kidney experts po in the country. That's why I am enjoining everyone to answer this panel discussion evaluation poll. And I'll read off the different items po. It's a 5-item poll, and I hope those who are still in the webinar are able to answer this. The first one reads, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons. Adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key COVID-19 health issues. So, tuloy-tuloy nyo lang po ang pagsagot sa ating final poll for this webinar. And as Dr. Susie mentioned, next week's episode is another special topic, but this time will be on vaccine, the clinical trials in relation to the vaccines. I know a lot of you have many questions po. Saan po ba tayo kukuha? Kukuha po ba tayo sa China, sa Russia? There's one from Pfizer and Moderna, then another one from Oxford, AstraZeneca. So all of these things I know are ruminating in your minds, and please try to gather as many questions as possible, and we hope that our members of the vaccine expert panel, and hopefully we could get secret pa lang po, but hopefully we could get our very special speaker for next week as part of this webinar. So as we are trying to slowly move into the holiday vibe, holiday season, I will just echo the message by President Dr. Elizabeth Montemayor of the Philippine Society of Nephrology. Please keep your physical distancing, always wear your mask and your face shields, and also dutifully and regularly wash your hands. Yung po talaga, the public health interventions really are key in us controlling the spread of this COVID-19 infection. So in behalf of the Stop COVID Deaths webinar series, maraming salamat po sa lahat po ng ating taga-subaybay at taga-panood. Makita-kita po ulit tayo next week, Friday, 12 noon to 2 p.m. Same time, same channel. I'm Dr. Raymond Francis Sarmiento. Keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others pain before my fears, the others laugh before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? My God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others pain before my fears, the others vows before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The others pain before my fears, the others laughs before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others pain before my fears, pushing on despite the tears. Please take us through another day. Just hold my hand, I will hold the line. I will hold the line.